Welcome. Our next speaker is Dr. Ana Zalbaza from Spain, in Catalonia, in Barcelona, and she is going to update us on the registry from the CEMCAT Center. So thank you very much, Ana.
Okay, thank you very much for the invitation. Are you seeing my presentation?
Yes.
Yeah, okay. So, as you all know, when the pandemic arrived, we all faced the question if our patient had a higher risk or not of severe COVID-19. And we wanted to look at this in our patients to find out if we could know the incidence in our patients, and also to evaluate the risk factors for susceptibility and severity. And how did we detect the patients in? Well, it's important to bear in mind that in that moment, at the beginning of the pandemic situation, in Spain, PCRs were only performed in hospitalized patients, so people were not diagnosed of mild, moderate cases. So we did this survey, an online survey that we sent twice, asking patients if they had symptoms or had been in contact with someone with COVID-19, to try to detect these mild, moderate cases mostly. And also, since the beginning of the pandemic, patients have been calling, or we have detected through the clinical visits, if they had COVID. So through this, we detected, we sent 2,903 surveys, which we got 875 response of 758 MS responders. Of those, we classified them in according to the European Center of Disease Prevention definition. We had 48 COVID-19 and 710 that didn't have COVID. So the incidence in our cohort in the survey was of 6.3. Altogether, since the beginning of the pandemic, we have detected through the other way 104. So in total, we have 152 until yesterday, or kind of like this. So in relation to demographics, it's a little similar to the MS typical demographics, with a median age of 48, predominance of female, relapsing forms. Up to 35% have at least one comorbidity. The EDSS, median EDSS 2.0, with a disease duration of 14 years. And only 4 had received corticoids in the last 3 months. Regarding DMTs, 75% of them were on a DMT when they had COVID. The division between first and second line were very similar, 50-50. And when in relation to the specific DMTs, we had a predominance of interferon, with the 25% almost, and of anti-CD20s, which altogether add up almost 29%. Which is a distribution, kind of the proportion we have in our center. Most of them were rituximab. We also had ocrelizumab and some that were on clinical trials. The treatment duration in years, the median treatment duration was of 3 years. And in relation to symptoms, the distribution was very typical, as the typical COVID-19. As a remark, we have 5% that have been diagnosed as asymptomatic because of they have been in contact. And luckily now, in the last second wave, we do have screening of contacts. So this is a little distribution over the pandemic. Most of the patients, we had them on the first wave, and we have had drops of patients, and we have a little increase in October. Regarding diagnostic tests, as I said, PCRs at the beginning were scarce, so we only have less than 50% tested with PCR, and we try to compensate that on June, where we had around 100 patients that we had diagnosed, and we did a serological screening on all of these patients, or the ones that accepted to be screened. So altogether, we have tested, or that have been tested, almost 90% of the patients. Of those, 63 have any positive test, whether either it's PCR, serologies, or both of them. Most of them have only PCR or only serological test, However, there are some that have positive PCR and negative serology, and positive, or the other way around, positive serology and negative serology. We don't have big numbers at all. We wonder if there was any relationship with the DMTs, so we looked at it. And this is well, a figure of a manuscript we have sent with 93 COVID-19 patients. So it's less than what we have now. And what we can see here is a proportion of positive cases. In gray, it's patients without any, without DMT. In blue, with anti-CD20, and in yellow, with other DMTs. And what we can see is that the positive cases of PCR, where the distribution is similar. However, when we looked at the serologies, anti-CD20 patients treated have much less, they don't arrive to 20% of seroconversion. Other DMTs arrive to, patients treated with other DMTs arrive to 50% of seropositivity, and patients without DMT arrive to almost 70%. If we look at the specific distribution in relation to DMTs, we see that patients without treatment with teriflunomide and with natalizumab do have a high percentage of seroconversion of up to 70%, whereas treatments such as rituximab or ocrelizumab, as I said, it was less than 20%. However, and luckily, this didn't convert in a bad outcome in our patients. Almost 90% of our patients had a mild and moderate disease. And we had a 10% that have had a severe critical cases, which concentrate mostly in untreated patients and in patients treated with anti-CD20s. This is the addition of all rituximab, ocrelizumab, and clinical trial patients. There are 3 that died. The 3 of them are without any treatment, were without any treatment. Those are 3 patients of almost 70 years with a long disease duration, progressive forms, high ADSS, without more than 2 comorbidities. So they all had known risk factors for a severe course. And as I said at the beginning, we wanted to know the COVID risk factors for both susceptibility and severity. And to do the susceptibility analysis, we only took the patients that answered the survey. So what we got in the multivariable analysis is the younger patients living in Barcelona that had contact with a positive case and with a longer disease duration were at higher risk of having COVID-19. We did a sensitivity analysis in patients treated with I'm sorry, I don't know what happened there. Anti-CD20 treatment. And we saw that younger patients and patients treated for a longer time had an increased risk of COVID-19. When we looked at the severity risk factors in the multivariable analysis, only age remained as an independent factor. And we think that's because there wasn't any or enough statistical strength, because we only had 9 severe critical cases against 84. So in conclusions, the incidence of COVID-19 in our cohort is very similar to the Catalan Barcelona, so the regional one. Younger patients living in Barcelona who have had contact with a confirmed COVID-19 person and with a longer disease duration presented a higher risk of COVID-19. Patients treated with anti-CD20 therapy for a longer period of time might be at higher risk of COVID-19. In our cohort, only age remained as a severity risk factor, and less than 20% of patients treated with anti-CD20 therapy generated an antibody response, which could be an important information for the vaccination. Luckily, almost 90% of our patients presented a mild moderate course. And overall, what this means is that MS patients present similar incidence, risk factors, and outcomes for COVID-19 than the general population. And that's it. Thank you very much.
Thank you so much, Ana. Is there any question for Ana first? I actually have a question about your CD20 patients. that generate less than 20% generating antibodies against the virus. And I'm wondering, and I might have missed it, but did you look at those 20% to actually see whether they were in need of a reinfusion, or they were coming out of the CD20 depletion?
So when were they treated for the last time? Is that the question?
Yeah, did you look,
Okay.
you know, because...
Yeah, we looked at that and we didn't find any relation.
Sorry?
I'm sorry. We looked at that and we didn't find any relationship with the seroconversion and with COVID severity, because at the beginning, and because Maria Pia, they found in the Italian registry that corticosteroids were related to severe curves. We wonder if the pre-treatment of all these rituximab and ocrelizumab as corticoids, and although the dose is much lower, this is more than 1 milligram/kilogram. So we try to look if this had any relationship with a more severe course, but we didn't find anything.
Okay. Thank you so much. So is there any questions for Ana? And then...
Can I?
Yeah.
Hi, this is Vijay Yadav from Portland. Thanks, Ana. Great presentation. I was just curious, either like from you or from the rest of the audience here, if you guys can comment on use of the vaccines which are coming out now, like the COVID vaccines and the CD20 therapies. What will be your approach, in terms of timing or recommendations? Or I'm pretty sure the discussions are probably happening right now. So any thoughts on that?
Well, there's I don't know much about it, but we have a specialist epidemiologist, Susana Otero, that has studied the response of vaccines, other vaccines obviously, on anti-CD20 treated patients, and they saw that there was a really low response of patients after their first or even second dose of rituximab, mostly rituximab because that's what we see. So in general, the expected response, I think it's going to be low. And I don't know about it, but Gavin Giovannoni, I think, there was a paper he published where they proposed that the vaccination is done just as far as possible from the previous dose. So, and this is what actually our epidemiology, well, when they vaccine our patients, they do this. Although, I don't know which is going to be the response. But there's also the immunologic, the cellular response, which we have to study, that maybe we could have there a gap of knowledge, and maybe there's something about it there. I don't know if that answers you.
Thank you. Thank you, Ana. So thank you to the three speakers. I'm just wondering whether there was any burning questions for Steve. I know the chat has been really active. Let me pause.